I've been working on HIV since really about 1981, 1980, 81. I was at UC San Francisco finishing my chief resident year and in internal medicine. And during my residency, looking retrospectively at it, we had patients coming into San Francisco General Hospital as early as 1979. I can remember specific patients who came in with what turned out to be pneumocystis pneumonia. We thought it was atypical pneumonia, TB. The first patient I saw was probably late 79, was a Haitian who had come through Florida to San Francisco, had what they thought was Burkitt's lymphoma, and then got septic, was admitted through the emergency room with no blood pressure, kind of semi-comatose. And we cared for him for about 2 months in that state, unable to clear his pulmonary infection, and basically just watched his immune function deteriorate over those weeks, worse and worse, and then he ended up dying with it. But that was the first patient that we saw, and that was late 79. I was doing my fellowship in infectious diseases and in general medicine, did an infectious disease year, and had multiple patients coming in through the emergency room, so much so that our census in the hospital was about 80% HIV-related illness. Now, at the time, we didn't know it was HIV. The virus wasn't identified until 1984. The lab test wasn't available until late 84 in kind of academic medical centers. So from the early 80s to 84, we didn't have a blood test. We knew that they were infected with a virus that was attacking the immune system, but we didn't know that the virus was not aerosolized. We knew it was bloodborne, but we weren't sure it wasn't aerosolized. So the fear within the hospital, nurses and doctors, was very high. It stayed high for years. Many didn't want to work with the population. We set it up as an inpatient unit, Ward 5A at San Francisco General, that just was AIDS dedicated, and set up an emergency room, nurse practitioner who would triage people kind of directly to the inpatient unit from the emergency room. We then started a AIDS clinic in late 84, 85 that was for outpatient care that I moved to in 85 and became the associate medical director of that, which was basically the medical director of the clinic, and Paul Voberdeen was over the whole service. And we saw really ended up following in the AIDS clinic about 25,000 patients with HIV, most of whom were gay men and injection drug users, a significant number of sex workers, predominantly African American. It was a cadre of nurses, nurse practitioners, physicians, social workers, hospice workers, all congregated on one ward that could pretty much take care of most of the service needs of an inpatient and then transitioning them home for care at home. The average person we would see would have 4 or 5 opportunistic infections and then succumb. So we knew the first time we met someone that we'd be dealing with their death, and it was a extraordinary burden, psychic burden on the staff as we took these young people through this kind of progressive disease that ultimately took them. Convening their families 3 or 4 times, you got to know the family. You got them through those opportunistic infections, so it was a kind of vigil where you'd gather the family thinking they might die in this admission, but you'd get them through, usually 3 or 4 of them, and then one would finally take the person. That kind of pattern went on for years, and after about 7 years, our staff, the physicians and the nurse practitioners who had been the main interface, began to show a lot of stress, a lot of kind of emotional lability. We all started to see it. We would react to things that shouldn't upset you kind of disproportionately. We were all in a post-traumatic stress mode, but had almost no insight into what that was. And internists generally don't talk about how they feel about anything, so it wasn't a group of people who kind of would voice what was going on with them. And but we realized that we needed to create an outlet, and started a meeting once a week where we would sit and talk about who died that week. And we had 15 to 25 people a week who would die out of the clinic, and realized that for some of those patients we connected to them and actually had to have some ritual acknowledgement of the loss. Some of them we actually grieved, and I think one patient would have a nurse, a social worker, a physician, usually a nurse practitioner, and the kind of volunteer staff that were very much part of the clinic. So it was usually a group of us who were impacted when a patient would go. I think that the camaraderie and collegiality that generated out of that bonded very strong relationships that have lasted till to this day. Most of those early clinic inpatient health professionals are still working in HIV. As we moved on, and we were the first clinic to start trimethoprim sulfa, the cotrimoxazole prophylaxis, and treating pneumocystis, just fell upon it, and started. We did the trials for the Chinese watermelon, compound Q, lentinan with shiitake mushrooms. These are studies that I ran. Paul Voberding did AZT, and ran the clinical trial that identified AZT as the first effective antiretroviral. I did DDI and DDC, which were very effective in killing the virus, but had side effects that made them not optimal. Then 3,4-T, 3TC, D4T, early 90s, began to do combination therapy in '89, but it was all monotherapy up until then with AZT. Then we added 3TC and D4T in combination. It wasn't until '94 that we saw an effective, highly effective antiretroviral in saquinavir ritonavir, and the protease inhibitors as a class of drug became available, and we really were able to take individuals who we could grow virus out of their blood, because we didn't have viral loads in those days. We would have negative cultures with these drugs, and the others we wouldn't. So we knew we had something that was different. In '91, so in the late '80s, I gravitated to doing more research, even though I still ran the clinic and still tended on the medical wards, and had thinking that we would kind of move away from some of the death and dying. We really didn't. It just changed kind of who our relationship with the patients in the research setting still were relationships, so it didn't really change that. I was just reflecting this the other day, that it really became acute in terms of the grieving and reaction to it when I had my first child, which was 91, and realized that all of the hundreds of patients that I'd followed in that role had died were somebody's child, and that bond and the intensity of the kind of parent-child relationship, as a young physician, intellectually understood it but didn't emotionally get kind of the depth of the loss. And it put it on a much more acute level for me and everybody else in the clinic who at that time were having their first kids. Same phenomena occurred. In '91, I was asked to come and help think about a response in Senator Kennedy's office, having looked at the burden of HIV in epicenter cities in the United States, 80–90% census saturated in emergency rooms and inpatient services with HIV-related illness, was involved in lobbying and then writing with Senator Kennedy's staff the Ryan White Care Act to try to, for the first time a decade after the epidemic had started, bring federal resources toward treatment and care of these patients. The natural history of HIV was, we called it the medicatization of HIV at the time, because everyone fully employed would get ill, use up their sick leave, go into disability, becoming permanently disabled, go through their resources as they would spend down, and everyone ended up indigent in those days, even with good insurance, because they eventually would saturate their kind of ceiling on their insurance premiums. That need was responded to in passing the Ryan White Care Act, and it brought federal resources to epicenter cities, San Francisco being one of them. Ultimately, there were 52 cities that were focused on, and brought money to states to help with laboratory support in testing, but also in prevention services, and then brought money from federal government to health centers that were in and kind of aligned with populations that were heavily impacted. I was the first director of that, and took what was a conceptual idea in the legislation and put it to a reflecting a programmatic footprint. It was in HRSA that occurred, and the people that we gathered for that, many of whom are still working in the federal government in this area, put together a program that really tried to develop effective mechanism to decide on what the unmet need was in each city, to prioritize that unmet need, and then to put programs in place. We defined the service portfolio that should be most appropriate for each population. For women, men who have sex with men, injection drug users, African American, Hispanic. The CDC took the lead on playing the prevention gurus of the country. And Jim Kern, that you referred to, was the first director of HIV services at CDC, and as you alluded to, really played a central role for many years in defining HIV, what it was, what opportunistic infections warranted a diagnosis of AIDS, making AIDS a diagnosis of less than a blood test in terms of your CD4 count. All huge contributors to our ability to understand, follow, monitor, understand the natural history of this infection, and in order to understand impact of antiretroviral drugs on the natural history became a critical piece. Through the Ryan White Care Act, we understood and learned the epidemic in the United States well, and learned a lot of and identified a lot of the models that were effective in bringing in high-risk populations that did not want to reveal themselves to medical delivery systems. And I think very much informed the world in how to mount a comprehensive response for HIV. I think the research component that was going on concomitant with this, in the first decade of the epidemic, it was NIH's resources that allowed us to care for patients in San Francisco. We put clinical trials into play It gave us the resources for medical infrastructure, for triage, for lab support, for all the subspecialty representation in the clinic that we converged there, dermatology, ophthalmology, neurology being the key ones, and allowed us to really define a model of care for an HIV clinic that really still holds today as the gold standard of what optimally you would want to put in place. I think in the 90s, I continued Ryan White until 94, 95, and then was asked to come down to HHS, the Humphrey Building, under the Assistant Secretary of Health and Donna Shalala, to set up an Office of HIV/AIDS Policy. This was right at the time that protease inhibitors were identified, so we started, conceived of, convened. I was the first chair of the Guideline Committee for Antiretroviral Therapy, Tony Fauci, John Bartlett. We convened the researchers that had identified the early antiretrovirals as the members of the clinic, of the panel. We had insurers on the panel, on the Guideline Committee, because this was the we wanted to make sure that as new drugs were identified that they were covered by insurance. So we wanted to give them a voice on the panel. We basically set it up to be very practical, who to treat, what to start with, how to change, what monitoring labs were needed. That guideline process became the model for guideline processes that popped up around the world after that. But this one became the most referred to, and still to this day is the one that is most up to date. As soon as a new drug comes out, it is immediately incorporated into the 27 antiretrovirals that are available, and clinicians are told which ones they should use and how they should use them, change them, etc. I think the office also set up and focused on the development of the Minority AIDS Initiative, which came around 96 or so. We found that with Ryan White, even pushing planning councils in epicenter cities to reflect the membership of the planning council should reflect the epidemiology of your epidemic, should show the demographics. If you have women, African American women, and MSMs impacted in your city, they should be on the planning council. That was a difficult change to kind of institute. It basically didn't work, and we didn't see a change in allocation decisions. Lobbying was hard and strong from AIDS organizations in most of the big cities, the AIDS foundations, to keep it broader and open to community-based approaches and to fund community-based approaches. So it became easier just to set up a minority AIDS initiative that focused on trying to close the gap that African American populations suffer disproportionately for really any disease you want to identify, and AIDS is certainly no exception to that. That disparity we put as the marker that we were looking at to try to increase the number of African Americans who were identified, entered, and retained in care, to focus on women especially, to look at the belt from in the southeast portion of the city of the United States that has a disproportionate number of HIV-positive African Americans, especially in rural settings, to target those communities and bring a continuum of care and services to them. That still is going on today and is in kind of a nice complementary relationship to the Ryan White effort. At the end of the, I guess it was in '97, I was asked to be the acting National AIDS Policy Director in the White House by President Clinton because they couldn't find somebody to appoint. I thought it would be a couple of months, and it turned out to be a year and a half. I continued the Office of HIV/AIDS Policy at HHS and all the duties there, but also spent much of my time in the National AIDS Policy Office, doing really looking at a pilot of moving toward putting treatment in sub-Saharan Africa. We had looked at this, and Helene Gale at CDC had started the Global AIDS Global AIDS programs at CDC, which focused on HIV in the developing world. It was through that project and program that I first traveled to Africa in any meaningful way. It was Zambia. It was my first country to see the devastation that HIV wrought on the continent. 78% of our epidemic being in sub-Saharan Africa. At the time, there was no treatment to speak of on the continent. We had the phenomena of going to hospitals in Zambia outside of Lusaka and seeing beds completely saturated with 3 to 4 people per bed, people underneath the bed, people in the hallway. I can remember very distinctly coming into an open ward where there's 40 people in a big room in bed, all with cryptococcal meningitis or tuberculous meningitis, and having 7 or 8 people have grand mal seizures all at the same time. And just watching that occur, all from diseases that in our country we would diagnose and treat. In these countries, in terms of opportunistic infections, they were without amphotericin. They would use a new drug at the time, fluconazole, that was not as effective as amphotericin. It's hard to give. It has to be given intravenously. It has a lot of kidney toxicity if you're not careful with it. And it's expensive. So a lot of countries did not have that drug. But it was the first moment I realized that we really did have a lot to offer what was going on in sub-Saharan Africa. We had gotten very good at treating opportunistic infections in the first decade of our epidemic. So good that we were able to anticipate often before the patient fully blew up with an opportunistic infection. And those who got good at it would save the patient more often than those who kind of waited until they were in an extreme moment. And I realized that even with antiretrovirals not really at that time being perceived as something that could happen in sub-Saharan Africa, that they needed to, and that opportunistic infections diagnosed and treated was a contribution we could make immediately. It also made me realize that the burden of disease was not in the United States in a very concrete kind of way, and that because we knew and we could, we had an ethical, moral obligation to mount and reposition the United States effort in sub-Saharan Africa to try to respond to that burden of disease. In the National AIDS Policy Office, we developed a plan to have 4 sites that we would treat it was about $36 million was what we were looking for. Set up 4 different sites, and we planned it all out, and we're ready to implement it. And under President Clinton, and then the Democrats lost the election, so it shifted everything in the White House, with Vice President Gore running at the time. That's when I decided I would go back to UC San Francisco and set up the Pangaea Global AIDS Foundation. Had 1 foot in the university and 1 foot in the community. And it basically was a nonprofit that focused on developing medical delivery systems for HIV and TB in resource-poor settings. And we did our work in South Africa, Rwanda, Uganda, and China, Ukraine, Eastern European countries. Did a variety of things, but it mostly was working with the government, setting up with their public systems of care, medical delivery systems that were in and of the government, not NGO parallel systems of care, all of which are still up and running. We were in Rwanda very early. In Uganda, the Infectious Disease Institute was done by Pangaea. then that is probably the leading training institution in the region now for doctors, and is doing much of the research that's going on in that area as well, but is a strong partner of PEPFAR and sees about 5,000 patients are on antiretrovirals in that setting now. And all the clinics that we started in both sub-Saharan Africa and in Southeast Asia and in China are all still up and running. Many of them are benefiting from the PEPFAR program now. PEPFAR was started by President Bush, as you know. I believe that when he first came in, I know that he was thinking that he wanted to identify a disease that was not controlled and to put resources toward it. From his first week in office, he latched on to the initiative that we had been working on in the White House and in HHS and in the State Department to try to figure out how we could put that into play. And he identified a group in that first week that we handed over all of that work to continue thinking about it. It wasn't until Tony Fauci phoned me up probably in 2001, 2002. I was in Rwanda at the time, and I get this overhead message, because Tony doesn't fool around, in the Nairobi airport as I was waiting for a connecting flight for Dr. Eric Goosby, get to this information center immediately. So I'm, thinking that somebody in my family has had a problem. And if you've ever been in the Nairobi airport, it's not easy to find somebody to ask a question for, but got someone. And it basically was Tony asking me to immediately come to Washington to have this discussion with Chief of Staff in the White House about an initiative. And he says, I can't tell you about it over the phone, but this is really something I want you to come and talk to. And so that was the first time that he convened myself, Paul Farmer, and Peter McGuinness from Uganda, and actually Bill from Haiti, Bill Pop. And it was two separate meetings about a month and a half apart, but it was a discussion about, can we really do this? Can you really treat a complicated disease in a resource-poor setting? And this was the first real indication that I had that they were seriously thinking about a large initiative. But it wasn't until the State of the Union address that we heard about it, and that's when President Bush announced PEPFAR as an initiative that he was going to support, and I guess it was 2003, and the rest is history. PEPFAR has been really the most remarkable program in I think, human history, focusing on one disease. We exceed the Marshall Plan in resources, and that came out of World War II. We are now at 3.2 million people on antiretroviral treatment, all of whom would have died. We have about 350 children, 350,000 children that were put through PMTCT programs. 114,000 last year alone were born HIV-free. We have about 8 million pregnant women that have been tested, 12 million prevention program interfaces. We have 3.8 million children, orphans and vulnerable children, that we care for from birth till they're 18 years old. Medical care for their seropositivity, their food, clothing, schooling. It's quite a remarkable contribution. And we have trained thousands of healthcare workers, trained physicians, set up labs throughout the sub-Saharan Africa, Southeast Asia, that are the reference labs for their countries. I think it's a remarkable contribution that the American people should feel very proud of.